Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice here at the supporting sponsor of OncoPharm, ETSU's Bill Gatton College of Pharmacy. I have some fun updates to talk about today. Originally, I was just going to talk about the new approval for the subcutaneous formulation of pembrolizumab. And then I was like, well, this is going to be probably a very popular drug because pembrolizumab is a good drug used for almost every cancer. Seems like a lot of indications. And the subQ dosage forms, people want to know about it. And then there are a couple things just kept coming up that I want to talk about. So I've got a few other updates to pass along as well. But let's start with the FDA approval. I believe this was last Friday, which would have been, I think, the 18th, for subcutaneous pembrolizumab hyaluronidase. And this is Keytruda QLEX. Now, this is hyaluronidase, not the hyaluronidase formulation, all the other subcutaneous formulations of monoclonal antibodies. And this is, it's a biologic, it's hyaluronidase alpha. It's recombinant, but it's not the human hyaluronidase, which is also a recombinant form included in these other formulations. Now, this is important that it's not hyaluronidase because we're going to see that this comes in a much smaller volume. As we go through the PI, one of the first things I noted is that this must, it says must, not should, must in the PI, must be administered by a healthcare professional. And it comes in a vial that has to be drawn up in a syringe. But one thing that if you are, say, an oncology clinic administrator, a pharmacy administrator, a lot of the revenue in these, for the pharmacy, these clinics, things like that, are tied to drug costs and drug revenue, and administering pembrolizumab or Keytruda in clinic brings in quite a bit of revenue. We don't give insulin in clinic routinely. It's a subcutaneous dose, and so if there were a subcutaneous drug that could be given for cancer, it's possible it could be given by patients themselves in clinic. And now, we're not there yet, but it says must be administered by a healthcare professional. And this goes either in the abdomen or the thigh, and there are some subQ biologics that can be given anywhere. Some just have to be thigh, some just have to be abdomen. This could be either one. Our dosing here, so there's an every 3-week and an every 6-week dose. So it's 395 milligrams every 3 weeks. Now that is with 4,800 units of hyaluronidase. That is only 2.4 mils. Like the daratumumab subQ, I think is 15 mil. This is a very small volume, just 2.4 mils, given over a minute. Okay, so it's not quite like getting, like a flu shot as far as the volume, how quickly it can be given. But this is pretty small volume and pretty fast delivery. And then the every 6-week dose is 790 milligrams with 9,600 units of hyaluronidase over 2 minutes, and that's 4.8 mil. Okay. Now, if you're on IV and you want to do the subQ, that just happens at the next dose. Or if you switch from subQ to the IV, it just goes at the next dose. And this should be given at least 2.5 centimeters from the prior injection site. Probably not going to be a problem just alternating left side to right side. And then don't administer any other subQ drugs in the same spot on that visit. From a adverse drug reaction standpoint, the way that this is approved is mostly based off of PK data, pharmacokinetic data, and similarity to the reference product. Similarity is not the right word, and we'll get to that. And there's a study in lung cancer patients, and the efficacy looks similar as far as response rate. But really, this is mostly about making sure that we're not underdosing patients getting this drug. When we look at the adverse drug reactions, they're basically the same for the subQ versus IV. There are some notable exceptions. So it looks like the musculoskeletal pain was 21% with subQ versus 30% with IV. So maybe that is a peak-dependent effect, that musculoskeletal pain. Or maybe it's just noise, right? It could just be noise. But that looks a little bit lower than with the IV. We saw decreased appetite at 11% on the subQ versus 21% on the IV. Okay, so now you're starting to think maybe the subQ is going to be safer. Well, leukopenia occurred in 61% with the subQ versus 52% with the IV. Okay, maybe that's just noise, more leukopenia. We don't think of that as a common thing with pembrolizumab. Now they are getting this along with platinum-based chemo, so maybe the sub-Q pembrolizumab somehow made the chemo more toxic in some way. Neutropenia, 58% with the sub-Q versus 49% with the IV. Grade 3 or 4 neutropenia, 28% with sub-Q versus 19% with IV. It's not nothing. It does seem to be a little bit higher risk of this mild suppression with the sub-Q when it's given with chemo. I don't think we have just a sub-Q versus IV PK data, at least not in the PI. I'm sure the folks that make this drug have that out there. All right, so now to the pharmacokinetic part of it. So if you read the FDA approval, they say that like the 95% confidence interval for the geometric mean ratio does not cross the pre-specified 95% confidence interval boundary of 0.8. Okay, so I'll talk about that in a second. So this is sub-Q versus IV every 6-week dosing. The geometric mean ratio for cycle 1 AUC total drug exposure was 1.14, so a little bit more total exposure for sub-Q versus IV Pembro. And that 96% confidence interval was 1.06 all the way up to 1.22. So to meet the threshold for for bioequivalence as far as AUC, that 1.06 to 1.66 could not start below 0.8 as far as that confidence interval. So doesn't even get close to being less, like pushing a chance that you might get less exposure. There's more exposure. And if you look at the cycle 3 trough, that geometric mean ratio is 1.67 with a 94% CI of 1.52 to 1.84. Now, I'm not misspeaking. They do say 96% CI for that cycle 1 AUC and 94% confidence interval for the cycle 3 trough. Why? I don't know. Ask a biostatistician. So we are looking like we're seeing more drug exposure for the pembrolizumab. Perhaps that then would be a reason for more hematologic toxicity. I don't know. One thing that I think is, and steady state is reached by 16 weeks with this formulation, okay? One of the things that's really interesting about this is the bioavailability of this is only 60%. So, and that's relatively low. That means, pembrolizumab, we could think of it in like the definition of economics, the study of scarce resources. Pembrolizumab is a scarce resource. It's an expensive resource. It's probably the most commonly used anti-cancer drug here in the States. And so that every 3-week dose of 395 is it's 395 milligrams compared to 200 milligrams IV. 790 milligrams sub-Q compared to 400 milligrams IV. So we are giving a lot of drug and not getting as much of that drug into the bloodstream and to the cancer microenvironment for probably some greater patient convenience, 1 to 2 minutes versus a 30-minute infusion. So there's some value there for that. I am curious as to how quickly this would be adopted in cancer centers to replace the IV. What the elephant in the room is, what's the cost of this going to be compared to the IV Keytruda or pembrolizumab? I think it's notable that the drug got FDA approval. The approval, or the folks that make this, I think it's Merck, they say they anticipate this to be available in late September. Checks watch, it's September 25th. It is late September. It's not available yet. There's no pricing available yet. And if you do the Google AI, first of all, the Google AI, they misspell pembrolizumab QLEX as QLIX with an I and an E. They don't know the difference between the I and the E. And then they say the price is the same price as the IV. Now, what Merck has apparently said in press releases is that it's going to be on par or similar to the IV, but we don't know yet. And so that's going to be kind of curious. If they try to make it on par with the IV, the cost per milligram is going to be lower, actually, while giving the same kind of total exposure to patients or getting more exposure. So kind of an interesting economic study as to how this is going to be rolled out and adopted for Keytruda or QLEX. But it's a drug that's used a whole lot, and if you can take a whole bunch of people getting sub-Q Pembro, that's going to be 30 minutes of chair time to 1 to 2 minutes. You can get people in and out obviously much faster. Okay, the other thing that came across my email was in the latest edition, or in the pre-release, I guess, of Journal of Clinical Oncology, Oncology Practice, was biotin supplements for hair and nail regrowth, a caution for oncologists. I love anything that's got caution, right? A cautionary tale. And I have seen patients taking biotin, and when I look at patients taking herbal and dietary supplements, I'm always like, all right, is there any known or theoretical reason this thing could increase the toxicity? Like turmeric is potentially a CYP3A4 inhibitor, can increase the toxicity of TKIs, and high-dose vitamin C has antioxidant properties, and theoretically it could decrease the effectiveness of doxorubicin, okay? I look for those things. So biotin can interfere with a lot of immunoassays and a lot of labs patients are taking with cancer, including like TSH, PSA, things like that. We had a patient recently where we were looking at their CA19-9, and it had kind of gone up, but they had stopped taking biotin. And it looks like there's a difference whether or not biotin can lead to falsely high or falsely low values based on whether or not it's a competitive or non-competitive immunoassay, the details of which I cannot explain. But anyway, the CA19-9 looks like it was non-competitive of an assay, and therefore biotin could have made the levels falsely low. So this patient with rising CA19-9 that happened off biotin, patient's feeling well, doesn't seem clinically like there's progression. That knowledge about that biotin could be helpful in interpreting those lab values. And, for example, pembrolizumab sub-Q or IV, you're checking TSH in these folks a lot, and if they're on biotin, that can affect those results as well. So this is something that is relatively common knowledge in the medical community, but I was not aware of this, that biotin can affect these lab values. And this article here, it's just even a page and a half, but they are saying that if they're more than 100 milligrams a day of biotin, that they should have a washout period of 2 to 3 days before having labs collected for those things. So I'll have that reference in the show notes. And the last thing I'm going to talk about today, I heard about actually on the X app. Somebody had talked about the 5-year outcomes for POLARIX, which were published in JCO actually online yesterday. And so POLARIX was diffuse large B-cell lymphoma in the POLARCHIP regimen compared to R-CHOP. So this is R-CHOP, take out the vincristine, add polatuzumab vedotin instead. Now this was published several years ago in the New England Journal of Medicine. We saw in the overall population an improvement in progression-free survival in favor of POLARCHIP, but no OS benefit compared to R-CHOP. So this is 5-year follow-up. These are patients, a little bit more than half were germinal center B type. Most median age was like 65. 440 patients in each arm. And we see largely at the 5-year follow-up the same thing, an improvement in progression-free survival favoring POLARCHIP, no difference in overall survival. And at the time, at the original publication, there was an efficacy hint that maybe POLARCHIP was better for patients that had a poorer prognosis, like a higher International Prognostic Index score, or those who had a non-germinal center B cell type, like activated B cell type. And so we have our 5-year OS results here, and just for all patients, the 5-year overall survival benefit was 82.3% with POLARCHIP compared to 79.5% with R-CHOP. Hazard ratio was 0.85, 95% confidence interval 0.63 to 1.16, pretty much the same, all right? Now, if you look at the activated B cell type, these are patients with diffuse large B cell lymphoma that have a poorer prognosis than the germinal center B cell type. This is called cell of origin, okay? COO, C-O-O, cell of origin. All right. So our 5-year overall survival rate for ABC, and this is maybe 35-40% of the entire cohort. So we're talking, more than 200 patients total, right? So it's a decent sample size. The 5-year OS with activated B cell, diffuse large B cell lymphoma on POLARCHIP was 84.6% compared to 69.7% on R-CHOP. That's a big difference. That's a hazard ratio of 0.49 and a confidence interval 0.28 to 0.88. That's a pretty wide confidence interval, 0.28 to 0.88. But you're seeing a very large impact effect. Now, it's not powered for this subgroup analysis, and so it's, that's still, there's some noise there. There is a little bit of perhaps disbelief if you go one line up in this forest plot and you look at the 5-year OS for germinal center B cell type. So the 5-year OS for comparison for POLARCHIP was 84.6, call it 85% ABC for POLARCHIP. Can you imagine someone just tuning in right now and thinking this is like Sesame Street with all these letters? All right, so POLARCHIP 5-year OS was 85% for ABC. For GCB, it was lower. It was 83%. All right? That's wild because we know that activated B cell type has a poor prognosis. And now we have a drug that looks like it can overcome that poor prognostic factor by using polatuzumab R-CHP. And the authors say that activated B cell type has more availability of CD79, so that B cell receptor is more out there. So maybe it is a very good target, especially for ABC. So 84.6% 5-year OS for ABC with Pola R-CHP compared to 69.9% with R-CHOP. And the GCB rates, or the GCB OS is 82.9 versus 82.3. Basically the same, okay? So, we see this strong hint that if you do have diffuse large B-cell lymphoma and you have ABC, that there looks like an overall survival benefit from R-CHOP. This is not a proven overall survival benefit because it was not powered to detect this in a subgroup analysis. Look at 106 patients getting Pola R-CHP that had ABC versus 129. That's small, but not terribly small by oncology standards. Now, if you look at the double hit, triple hit positive folks, you see actually, and this is how you can get into trouble with subgroup analysis, you can see that the 5-year OSRR CHOP is 89.5%. Very good. We know that double hit, triple hit, they probably don't do well on R-CHP. Here, their 5-year OS was 89.5%. For Pola R-CHP, it was 76.3%. That hazard ratio, point estimate is 2.44. Looks great. 95% CI, 0.49 to 12.11. Incredibly noisy, incredibly wide. We have fewer than 40 patients in that cohort that will double hit or triple hit positive. So that's an example of kind of, I think, over-relying on the subgroup analysis. But if you look at that ABC, we have that PFS benefit from before that was seen that's maintained in the 5-year survival or the 5-year follow-up. We have this trend of OS benefit. These are nominal hazard ratios. It's not powered to detect this, but if I were a patient and I had diffuse large B-cell lymphoma, ABC subtype, I would not want R-CHOP. I'd rather have Pola R-CHP based on this data here. Okay, so that is what I have for you this week, and I'll have links to that Biotin commentary and the 5-year outcomes of POLARIX in the show notes. Thank you all for listening so much, and until I talk to you again, remember, doses matter.